Okay, so good morning everyone and welcome to a new case reporting session.
So this is a native CT scan of a young age female patient with history of trauma. I'm scrolling through the axial slices. This is the soft tissue window. Okay. There is oral contrast given as well. Okay. So the first note is that there is...
Is there any IV contrast in this image or just oral?
It's just oral contrast.
In this sequence, in this acquisition,
Yes,
it's just oral.
It's just oral contrast. There is an area of like consolidation involving the segment, the lingula of the left lung.
Okay.
In addition, there is heterogeneity, heterogeneous area involving the right lobe of the liver. There is no free fluid, and the spleen appears to be unremarkable. The oral contrast seen in the stomach and the small bowel lobes. The pancreas, as per native scan, also appears unremarkable. Oh no, there is dense ascites.
Okay.
Subhepatic area, but there was no pleural effusion. Small bowel lobes are outlined with contrast down to the ileum. I think appears to be unremarkable. The free fluid is also seen within the pelvic cavity.
What do you think the most important, let's say, reason for giving oral contrast to this particular case?
To exclude any bowel injury.
Any bowel injury, you are looking for contrast outside the bowel. Leak. Okay. So, is there any?
No, there is no contrast outside the bowel lumen.
And other way of excluding is to, if we did not give oral contrast, how can we exclude bowel injury?
Without oral contrast?
Without oral. What do we do?
If there is free air,
you do a lung window.
Yes, lung window.
On the abdomen, always. Especially in trauma cases. Yes. In all cases, but especially in trauma cases, and look for air outside the bowel loops. Even tiny bubble indicates some sort of bowel injury. Okay?
So I'm scrolling through the lung window, looking for any air bubbles, extraluminal. I cannot identify any...
What are these lines? You see these lines? What are these? Are they normal or abnormal? Are they good or bad?
Ring artifacts.
They are ring artifacts.
It's a faulty detector.
And indicating faulty detector. There is one of the detectors is not working and creating these lines, ring artifact. And when there are more than one detector not working, then these artifacts will get bigger and bigger, and you'll be in a very bad shape. The images will be very bad. So you need to call the engineer and replace some detectors. This is part of the physics that you, as a radiologist, has to know to make good images. Anyway, continue.
Okay, so I think these are the conclusions of this native study, that there is dense ascites, there is heterogeneous area involving the right lobe of the liver, and there is the bilateral right middle lobe and lingular consolidation. So I want
right middle?
Yes, there was a smaller area of consolidation, the right middle lobe as well.
Can you show? Yeah.
The middle lobe.
Yeah, a little bit. Okay.
Yes.
So now what should we do?
Contrast study.
Give contrast.
This is the contrast in the arterial phase. Yes, now in the arterial phase, the heterogeneous area involving the right lobe of the liver is more obvious, and it is non-enhancing. And at the segment 6 of the liver, there is an apparent laceration, obvious laceration involving the right lobe of the liver. So it's most likely to be a liver laceration with a large non-enhancing subcapsular hematoma, and this is the explanation for the subhepatic and pelvic dense acidic fluid. The spleen is enhancing normally, and there is no injury to the spleen or to the kidneys.
What's the most important or most critical finding in this case?
It's the liver injury.
Liver injury or liver laceration. And when we see such a injury, what's our next step?
Next step is to
Should be grading
yes.
of the liver injury, because it will judge the further management.
Yes.
Okay. Which grade do you think this is?
There is an American scale of trauma, American Association of Trauma. It appears to be deep lacerations. So I think it's a grade 4 or...
Perfect. Exactly. It is grade 4 liver laceration. And the grading system will not explain it here or now. If you are interested, open the internet and look it up. According to the depth and the associated findings.
Hematoma.
Yes, the hematoma and things like that. Excellent. Very nice. So this is a grade 4 liver injury.
We should also check the bone window.
Definitely. Definitely. Let's do the bone window. Where is the bone window?
Because of
I think fall from height. I think fall.
opacity of the lingular
Contusion.
contusions.
Contusions from trauma. So I think in the bone window is good. Nothing there.
I'm presented with MRI of a 30-year-old male patient presented with multiple recurrent attacks of fits.
Uh-huh.
I'm scrolling through the sequences. This is T1.
T1 what?
T1
Axial, coronal, sagittal.
T1 axial
With fat sat or without fat sat?
without fat sat.
Without fat sat.
Okay,
Good.
this is T1 and this is T2. Because I can see settle temporal lobe.
Where is the temporal lobe?
This one.
Okay.
Edema.
Increased signal intensity.
Increased signal
Increased
intensity,
T2
yes.
signal
I
intensity,
think it's
probably.
bilateral. Doctor.
It's bilateral.
Yes.
Okay.
I'm checking for flare sequence. This is flare coronal. Yes, it's markedly settle, but since it is fits, so I should check for these regions. Most common region for convulsion.
Which is? What is the region? What region are you talking about?
Hippocampal.
Hippocampal and parahippocampal. Looking for what?
For medial temporal sclerosis.
Mesial
temporal sclerosis.
MTS.
Yes, or herpes encephalitis.
Herpes encephalitis is another code.
Encephalitis.
Good.
Or, for example, not infarction, because the history is not goes with it.
Okay.
maybe-
What are the findings that you expect to see in cases of MTS or mesial temporal sclerosis?
The atrophy of the hippocampal area with the prominent of the lateral of the temporal bone of lateral ventricle
And
high signal area.
increased T2 signal intensity.
Exactly.
Good. Do we have these features?
Not apparently. I think the right side.
The first thing you said was an increased T2 signal
It was
intensity. You saw it on the T2
Yeah,
Aslan.
because it's increased signal, but
Just you need to make a little bit harder window. And now, is it apparent or not?
it is apparent at
Okay.
the left side increased signal, but the volume is at the right side is smaller. But I think it's normal. I think it's normal, but mildly enlarged at the left side.
The right side is normal and enlarged on the left side, or which one is normal?
Doctor, the signal is
Listen, to identify MTS, there will be atrophy of the
yes.
parahippocampal. atrophy of the parahippocampal gyrus and means that the temporal horn will be larger.
Exactly.
So when don't focus on the brain, focus on the horn of the lateral ventricle. So the horn of the lateral ventricle here, which one is bigger, here or here?
Here.
The
lateral horn here.
the one
Yeah.
on the right side, it's larger.
Exactly.
This indicates that the right parahippocampal gyrus is
Atrophied.
atrophied. Height first. Second, normally the temporal horn is slit-like, especially in young people. In older people with brain atrophy, you might see it a little bit prominent, but it should be symmetrical. If it's asymmetrical, normally should be slit-like. Slit means line, just a line, okay? And is this slit-like?
No.
Is this slit-like?
No.
So both of them are atrophied. However, it's more prominent on the right side, okay? And MTS can be unilateral, can be bilateral, can be symmetric, can be asymmetric.
Yes.
So this should be reported as a case of mesial temporal sclerosis. Bilateral, more on the right side. طبعا, properly, there is something called volumetry when we measure the volume of the parahippocampal gyrus, but we will not. Takes too time and complicated process, so we will not do it now. Okay, and there is no diffusion restriction. Don't worry about this. Okay, now.
I'm presented with axial CT scan of the chest, native study. Mediastinal window.
What's this? Excellent. Ring artifact. Never forget it again.
Mediastinal window normal. Lung window.
Lung window? Okay. This is lung window.
Multiple patchy ground glass opacity in the lung base and peripherally most. And some of them show peripheral.
Some of them show
reversal sign.
What's the reversal sign? I don't know.
Central ground glass and peripheral consolidation.
Okay. So, what's your impression?
Organizing pneumonia.
Mm-hmm. Other possible DDX?
Eosinophilic pneumonia. Chronic eosinophilic pneumonia.
What else? Summarize your findings. Put them all together and present them to me.
Yes, the axial CT of the chest of middle-aged female presented with progressive SOB, progressive cough,
Okay.
cough and SOB. In the lung, I saw multiple patchy ground glass thrombi consolidation. My diagnosis.
Any pleural effusion?
No.
Any lymphadenopathy?
Clear mediastinum and no any pleural effusion. The case at the top of my differential diagnosis, organizing pneumonia. Second one, chronic eosinophilic pneumonia.
I will give you a hint. Like you've never think of it, but it's been there from the beginning. Look at the date.
Yes. COVID?
Definitely.
Yes, lower lobe peripherally without lymphadenopathy, pleural effusion.
Sometimes the hint is everything is your responsibility, even the date of the exam. This was done on 2020, so it was the year of the COVID, okay? And next we should do the COVID scale. In each lobe we estimate how many percent is involved, and we add all the lobes together.
Yes, T1 and T2 sagittal without fat sac at the level of the L1 and L2 vertebral body, especially at L1, there is a complete there is destruction of the vertebral body with regular end plate and also the intervening disc loss of the there is the decrease hydration and decrease space.
Decrease hydration, more increase hydration. Decrease hydration. Good.
Decrease hydration and decrease height. And also there is in the retrospinal at the anterior
deep to the anterior longitudinal ligament.
Also there's look like some collection and also at the anterior paraspinal anterior longitudinal ligament there's also some collection.
So wait, now what are you thinking of?
I think of the infectious cause causing destruction of the vertebral body with little preservation of the disc space or I think of TB first differential either TB or spondylitis or spondylodiscitis.
So what is your next move? What's your next step?
See the contrast study.
Okay, see the contrast. So now you have T1 pre and post contrast. And what do you see?
There is peripheral enhancement. There's a collection involving the L1 vertebral body and also the upper part of the L2 vertebral body with peripheral enhancement and pressure effect on the spinal cord at that level.
At the codoequine, not spinal cord. You're talking about L1, L2.
Yes, at the lower part of the spine. Pressure effect on the anterior thecal side and the spinal cord. So also there's another lesion in the same other vertebra L3 vertebral body. So this is a case of TB spondylitis with multiple level involvement.
What about
we also should examine the paraspinal area for involvement of the psoas muscle.
Do we have any? So basically what we have is an abscess.
Yes.
Extending intraspinally and to the outside.
Yes.
Mainly at the level of L1 and 2, I think. Okay. So you said most likely is? TB. Why?
Because there's...
It could be bacterial spondylodiscitis, pyogenic?
Could be, but most probably is the TB because there's destruction of the vertebral body with little preservation of the and also there is the paraspinal collection anterior with skip lesion more than one level involvement.
Why you say skip lesion? Where is the skip lesions?
There's another involvement and more than one level.
Yep.
Anterior paraspinal area involvement.
Show us where is the more than one level involvement. You can clearly see the subligamentous spread.
Yes.
You can clearly see subligamentous spread preserving the disc.
Yes. Yes.
which is a typical feature of TB spondylodiscitis, also known as.
What's the
Excellent, beautiful.
So I'm present with MRI of shoulder joint.
Right or left?
This is right shoulder joint. Okay. High stair sequence. Showing there's high signal involving the there is هنشوفه بالT1 ممكن there is fracture line. Okay, T1 sequence. There is edema. There is a region of hypointensity involving the lateral part of the head. With icing, there's a fracture line.
Okay.
Black line, mungkin fracture. And jalan T2. Coronal T2 sequence of the right shoulder joint showing there's I see minimal joint fusion with yes there is fracture or there is ممكن صار avulsion fracture بالtuberosity high.
I don't know, are you asking or answering? You have to tell me.
Okay, بالstair.
So basically what we see is, طبعا this is movement artifact, patient is moving.
Yes. Surrounding all high signal.
There is a fracture line and surrounding bone marrow edema involving the greater tuberosity of the humerus. Okay. Look at the shape of the fracture. It's an indentation rather than a fracture, not comminuted fracture. It's an indentation, V-shaped. Okay. So what causes this type specific indentation fracture? If something is indenting it from outside, صح? If something is pressing on it, then there will be this kind of fracture. So this fracture is called Hill-Sachs lesion, definitely. And whenever you see a Hill-Sachs lesion, you should look for Bankert. Look, is there any?
Yes, I think there's a fragment.
There is a bone fragment at the anterior-inferior aspect of the bony glenoid.
Yes.
Okay, it's not displaced, but there is a fracture line. You can see. If you want to ask the patient one question, what would you ask him?
Shoulder dislocation.
Was your shoulder dislocated or not? Okay, and if he says yes, it was dislocated, relocated, then you are 100% sure of your diagnosis, which is Hill-Sachs Bankert lesion. Okay, and this should be treated, or there will be what? Recurrent shoulder joint dislocation leading on the long run to shoulder joint osteoarthritic changes. Okay.
About also we should check the tendons and the.
Sure, definitely you should check the tendons for any tendinous injury. If you can't see a nerve, I don't think on this quality image nerves will be. It's not a good quality, I know. And of course, there is a shoulder joint fusion. There is some edema of the surrounding muscles expected. Okay. However, the shoulder is relocated, but there is an obvious Hill-Sachs Bankert lesion. Okay. And usually it is due to, and which type of shoulder dislocation? Anterior or posterior? Anterior shoulder joint dislocation, which is the most common or the less common?
Most common type.
The most common type is anterior shoulder joint dislocation. Okay.